it's well known that the higher the dose, the more toxicity with CTLA-4. So that's the mechanism. The more you unleash, the more you basically inhibit CTLA-4, eventually the more you're going to unleash the immune system, and you may have autoimmunity. So there's nothing new in that finding. We've seen it with ipilimumab as well. Higher doses of ipi have higher toxicity. So I don't think that's a surprise. As far as to, why are we seeing higher response rates on the 75 milligram dose level? We've seen 19% versus the higher dose level of 150. I think you have to put things into context. So really, if you look at the disease control rate, the disease control rate is the same on both 75 milligram and 150 milligram arms when combined with Balstilimab. It's 55% and 54% respectively. So I do think both have activity. However, it is possible that some patients on the Botensilimab 150, because there was, a higher incidence of grade 3 toxicity, it's a 10% increase, absolute increase in grade 3 immune-related toxicity with colitis, diarrhea, and other IO-related toxicities. It's possible that some of these patients, unfortunately, had to stop treatment early or had to receive, immunosuppressive agents that masked their responses. So that's a speculation, but I do think there had been, a little bit more discontinuation likely on that arm, which is expected, and that may have compromised the response rate. You also have to take into consideration the fact that this is still not, a large study, and the confidence intervals may be still a little bit large for the response rates. The design of the study was to report the data on each of the single arms, and it was not really designed to compare one particular arm to the other in a statistical fashion. But I do think what the study tells us is that the optimal dose is 75. You don't see higher response rate with the 150. You see a little bit lower response rate, and the 75 is safer. So there's really no reason to pursue the 150. Yeah, first I have to say that it's no surprise. 21 patients were treated on the combination arm. There were no responses, but you have to put that in the context of what we know. Both regorafenib and trifluridine have response rates of about 1% to 3% in this population. And this tells us that, BOT/BAL is definitely, in my opinion at least, preferable over trifluridine and preferable over regorafenib in this particular patient population. And I think what's more important to patients is not just the overall response rate, but the durability of the response. And as we reported this ASCO, the 70% of the patients who had responded to treatment had not progressed at this stage, at this point. And so that durability of response is quite promising. We hope to report on that data as it matures further. But I think this is an unmet need for our patients, and I'm really hoping to see those agents in the future in the clinic so that there is more access to CTLA-4, PD-1, or effective CTLA-4 and PD-1 inhibitors such as Botensilimab and Balstilimab. My understanding, the phase 3 is going to be hopefully launched later this year, and the primary endpoint is overall survival, because at the end of the day, what you want to show is that we're improving the overall survival of patients, and it's going to be compared to the standard of care arm. The standard of care at this point is trifluridine bevacizumab or fruquintinib or regorafenib, but I do think that trifluridine bevacizumab is the most established and most used, and I think one would hope to show improvement over that combination to make it more meaningful for our patients.